Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Brahm Miller is a certified prosthodontist who lectures extensively on implant therapy and all ceramic technology, focusing on the collaboration of surgeons, dentists, and technicians to achieve better patient outcomes. He's been recognized as one of the top clinicians in continuing education by Dentistry Today.
My name is Brahm Miller. I'm sure you're familiar with that Vancouver team that you see periodically, the Seattle Study Club. And my practice inspiration is both for myself and for anyone else. It's kind of a taster's menu. And I've honed it down to looking at abutment design. And I'm going to correlate that with what I think is going to be the next generation of actual information transfer of the emergence profiles and hence the design of these abutments in the future. And certainly we understand that optical scanning has become a very important part of our practices, or is going to become that. And so I want to share a little bit with you. Again, it's a taster's menu of really what I want to say. So what do we know today at this moment about optical scanning, and how comfortable would we be in adopting that technology? Personally, I think it's turned the corner. It's not as literature-based as I would hope it would be, but we do know that capturing digital data sets and data is extremely accurate. And the precision and accuracy of the scanners that are coming onto the marketplace are incredibly good. And I certainly took every effort to try to figure out whether I would be happy with the literature versus doing, let's say, a little bit of our own research. In any case, I don't think it's a dream anymore, but we don't have an exhaustive literature base for this, but it is coming out much more seriously. And certainly I think you see that most of the presentations that are given have, in some of the congresses, have at least 30-40% digital dentistry as part of the content. So regardless of what the literature is actually saying or what the sellers are saying to you, I think you should understand that most of what the laboratories do today is digital, and most of what we do, unfortunately, as information to give to them is analog. And so we're not quite in sync. And a recent ADA study compared 6 intraoral scanners, and yes, they said, you know, this one might be better than that one, but I think that in a sense there was no major significant deviation or difference between them. So these machines are pretty good. So what did we do to convince ourselves? And this, by the way, all ties into this abutment design. I'm not trying to get off track. We took a number of patients who had long-standing implant crowns in position with ideal soft tissue contours, emergence profiles, and they were screw retained, so they were easily retrievable. We unscrewed them, and we put them through a digital scanning process and worked in a reverse direction. In other words, asked for the fabrication of the components, and then I went about assessing clinically whether these designs were accurate, filling the profiles correctly, supporting the soft tissues, and whether the crowns that went over these abutments, whether they were hybrid, and I'll show you that in a moment, or cemented, would co-support the soft tissue and as well have the proper interproximal contacts and occlusal contacts. So this is really interesting to me. It's kind of like a non-biased study. So this is the case, one of the cases. We removed a molar. You can see the subgingival prosthetic envelope. It's ideal. healthy tissues. And you can see the crown that I actually removed. So we're going to work on that site. And I'll say this, and for those of you who know Sonia and myself, that your auxiliaries can actually do all the scanning and do most of the work for you. And don't take it lightly. This is not my auxiliary. This is Sonia. But she was so kind as to do some of this scanning for us. And what you see on the screen is the scanning of that emergence profile. And it doesn't take very much time at all. If you know, it's sort of a bit of a learning curve. And in addition to that, we scanned the position of the implant using a scan flag or a scan body. So I just want you to keep that in mind. So what we're doing effectively is, with the patient in this particular case, scanning the upper arch, scanning the lower arch, scanning the emergence profile, locking it in, so we can do that right off the bat, and it's not going to change dimension, and then scanning the scan flag or scan body to record the position of the implant. And we are scanning the bite. No models, up in the cloud. That's all we need. So by modem, obviously, everything is going to the technician. So what happened was, I am sitting at my computer in my office, and 3,000 miles away, my technician and I are sharing and communicating how to design abutments. Now, it's pretty hard to do this with a stone model and a wax up, which you FedEx one side of the country to the other. It doesn't make any sense. But what's interesting to me is the fact that there was uncertainty with these technicians as to exactly what to do in terms of the design. How do we support tissue? Where's the margin? How deep do you want it? And what do you want it to look like at the end of the design? But it wasn't a question of what they didn't know and what I know, or what I think I know. It was more my ability to open up an avenue of communication and share and educate. We were actually educating each other, and that was the strongest point of this whole exercise. So the first attempt, as you can see on the slide, was this little flat top design. And I said, well, I worked so hard on getting that emergence profile, why don't we do something a little more elaborate? So we walked through it with each other. We changed the margin position, we changed the support of the soft tissues, we changed the contour of this abutment, which happens to be a full anatomical abutment. That isn't necessary. But the beautiful part of this is trying to tell my technicians who are so far away really what I'm trying to achieve and not make the case go backwards. And all along we have a 2D overlay which is showing us, for example, interocclusal distance and things like that. So there's many, many little things that these intraoral scans carry within the context of what they can do. And it's just amazing how comfortable I feel working with the strength of this digital data. So this is the model printed from the data. It's not unlike any model you would see. In this case, it looks black, but that's irrelevant. And you can see the position of the implant, the emergence profile, and the final abutment. And as we know it in this industry, final abutment in this case, and metal stem, anatomically designed, a little over the top. Nevertheless, it's just a point of information that we can design anything, mill it. And you also see the final milled crown. The crown, I will tell you, is neither stained or there are no special effects in it. We were doing simply a measure of accuracy and trueness, or trueness, which is accuracy, and precision of manipulating the digital data through to a final restoration. And here you see in a composite form the emergence profile. That abutment design looks like it's gold anodized. It's irrelevant as well. And I'm seating the crown and then the full seating. And I would tell you that for every case that we manage this way, looking at it from trying to develop what would be, I would think, the best way, and that is from the final restoration backwards. We had beautiful interproximal contacts, the way I like them. We had the kind of occlusal contacts that I was expecting in the occlusal build-out. So that was really encouraging to me. And if you look at it through these graphics, you can see, you look at the position of the abutment, what it looks like, and the crown on top of that abutment. And in this case, it's a screw hybrid type restoration, a monolithic zirconia crown milled with a titanium base, which is resin bonded to the body of that, and the crown in position. So we have total screw access retrievability for these. I usually do all of my posterior crowns as screw retained. And you are probably more familiar with smaller abutments, smaller titanium stems. It doesn't really matter. I can show you a whole variety of designs that I use. The key here is, can we take that digital data and really feel comfortable that it has some trueness to it? And here's a better look at those hybrid crowns where you have screw access. You notice the milling of the ceramic goes down into the chimney so that we can treat that area and bond something into the, hopefully a small hole on the occlusal surface, and make it disappear, and its associated metal stem. So that leads me into a very brief explanation of how does this help me in terms of cementation when I have to cement it. You know that the literature is plagued with information about cement remnants being left over, how difficult the cementation process is, and the possibility of that leading into a generalized inflammation in the area, and possibly leading to bone loss or peri-implantitis. So my interest in this really works from a different angle. A lot of people go around talking about how impossible it is to cement things without trapping this cement. Whereas I come from a different angle and I say, you do the designs of the abutments correctly and the crowns, and you minimize the potential for trapping the cement, then you can take control of the process. So the literature is pretty much all over the place. Some contest that cementation, I mean, going through systematic reviews, leads to less problems, biologically perhaps, but more or less technical problems. Others contend that screw retain restorations are easier in terms of retrievability and therefore preferred as the type of attaching to the implant system. So just to give you an idea, why abutment design, whether you're doing it digitally or otherwise, analog, is so important is because if your abutments are not designed correctly, then, and as shown in this case, quite deep on the distal, if you want to isolate the area, it becomes rather difficult. You try to place a cord gently, and it starts to well up, float around in this area, and then you induce bleeding, and I think the process goes backwards. So when I'm designing these abutments, I'm looking for the minimal amount of displacement under the tissue. I'm looking at treating my abutment design very much the same way as a natural tooth, which means that we have the rise and fall of the preparation 360 degrees, and we are able to take an excellent quality tissue, which is another part of the program, but for this purpose, we're just talking about design. Place a cord, have that tissue hugging the cord hugging the abutment, and use it as a deflective mechanism for cement. And if I had a dream, it would be the left side of your screen where you see a cutaway of what an abutment would actually look like for me. It has more of a concave body as it emerges transmucosally. The margin is minimally submerged or minimally subgingival, and that allows me to use this deflective cord with a minimum of fuss. So this is a very nice example compared to the other one of what an abutment would look like in my hands, fully seated, ready for the cementation process. Because what we get back from our technicians is an abutment and a crown. We know they impeccably fit because we can evaluate them benchtop, and all we have to do is put them together, cement them if we're cementing it, and we seem to have an inordinate amount of trouble doing that. So once we have the tissue, and that's a very big part of this program, once we have the abutment design, there's another little thing that you can employ, because when you introduce cement into a crown and you place it over an abutment, and in this case cementable or cemented restoration, the cement wants to run in a variety of directions. It wants to go into the sulcus and go right to the head of the implant. Very hard to clean that out. It wants to also rise along the body of the abutment and try to get out of the edge of the crown, but there's no hole, there's no vent. So what we do is we leave the abutment open. We just cover the head of the screw. We leave the entire chimney open to act as an internal vent. So as we cement, we have a deflective cord to inhibit the cement from going deeply into the sulcus, and we have an internal vent, and the cement will go down, hopefully, into that vent and minimize any cement trapping. So that, I hope, is inspirational to you. It, nevertheless, no matter what it is that you do, whether you're doing digital work or otherwise, you have to still be very cognizant of the fact that you have to carry out your own steps and be careful through the whole process. So let's give our patients the best possible leg up to have a healthy, long, standing, predictable restoration. Thank you.